Okay, so our topic today is kidney diseases. So the learning objectives, of course, that we have, we hope that you all learn to and hopefully use and understand the pathophysiology of the kidney, discuss CKD, underlying etiology and stages based on the estimated GRF, define characteristics associated with each condition, which of course we're going to go through the AKI, the ATN, and the CIN. We're going to review some coding regulation and guidelines associated with each condition. Then we're going to discuss all the clinical educators, listen to me, clinical indicators associated with each condition, and of course go through case scenarios. We're going to outline some potential query opportunities for each condition and then review a couple DRG assignments for each condition. Disclaimers. The materials designed and provided to communicate information about clinical documentation, coding, and compliance, of course, in our educational format and manner. The presenters are not providing or offering legal advice, but rather practical and useful information and tools to achieve compliant results in the area of clinical documentation, data quality, and coding. Every reasonable effort has been taken to ensure that the educational information provided is accurate and useful, and applying best practice solutions and achieving results will vary based on your hospital and facility with your clinical situation. So let's talk about anatomy and physiology of the kidney. I think this is a really nice snapshot of the kidney anatomy because it gives you all the information that we're going to be discussing soon. So it's a great little picture to have. So when it comes to our A&P, of course, we know it's all a bean-shaped brownish red in color, and it's located retroperitoneally. So it's behind and outside the peritoneum. So it's not within the peritoneum area. Its external protection includes the ribs, the abdominal muscles, as well as the back muscles. And your internal protection is fat deposits that surround the kidney. So of course we have two internal structures. The two parts are the cortex and the medulla. Now, the cortex is the outer portion of the kidney, and that's where your nephrons, the structural and functional parts of the kidney that produce the urine is noted. And let's look at that. That's on slide 6. Here it is. So this is a nephron, okay? Then you have the medulla, which is the inner portion of the kidney that contains the loops of Henle, vasa recta, and collecting ducts within the nephron. Oh, I got it backwards. So this is the cortex. So here's your cortex, and you can see that this is the outer, and where the renal artery, pelvis, everything, the blood vessels, all right? It gives you a nice little snapshot of the internal. And then this is the medulla, the internal, right? And this is where when I was looking all this up again, I was like, oh, Bowman capsule. I remember that. I remember Lupa Henle. So it just gives you, how the blood flow is and between the artery and the veins and the tubules. Mm-hmm. So when it comes to the functions, there is a lot of functions that the kidney does, right? It definitely controls our blood pressure, as we all know. It controls water balance too. So why do you think nephrologists are always called in when somebody's in acute heart exacerbation and they're fluid overload? They're calling in nephrologists because they know how to handle the water balance, the fluid balance within the body. It also regulates electrolytes. It excretes the waste products, your urea. It regulates the acid-base balance, even regulates the RBC production, maintains renal clearance, and even secretes prostaglandins. And it synthesizes vitamin D to an active form. The big thing that we're going to look at today is your urine formation. We're going to do a little deep dive into that because I think it's important to know what we're looking at when it comes to the urine background. So for urine formation, It is formed through the nephrons through a 3-step process. So you have your glomerular, if I could talk today, filtration. You got your tubular reabsorption, and then you have secretion of the tubules. So substances that may be reabsorbed are usually your amino acids and your glucose, right? Our amino acids are protein builders, right? We know that. Your substances secreted by the tubules could be your sodium, chloride, potassium, right? That's our chemistry panel, our electrolytes. Your bicarb and your glucose also. And then your urea, creatinine, and your uric acid. So sometimes if the kidney's not functioning properly, it may not secrete your sodium or chloride or potassium, right? It may lose it. So then you have hypokalemia, or it keeps it in there. And then you have hyperkalemia. So that's why it's really important to understand what substances are reabsorbed and what substances are secreted in order to maintain that kidney function. Now, your ADH, your antidiuretic hormone, this is also known as vasopressin. So poor oral intake leads to increased blood osmolality, and that stimulates the release of the ADH. So your ADH also acts on the kidneys by increasing reabsorption of the water, thereby returning the blood osmolality back to normal. This is a lot of pathophysiology. So, just try to get your brain wrapped around certain aspects of it to help you when you're reviewing a record, okay? So when it comes to your osmolality and your osmolarity is the ratio of solute to water. So salt and water are needed to control the volume of serum and urine osmolarity within the body. So even a little change, a very slight change in the urine osmolarity would cause the kidneys to conserve water, and then one would want the desire to drink water. Okay, so it's all that reflex stuff that's going on that you don't think about it. You just do it because it's like your body says, hey, you're dry. Oh, I better go get some water. I'm thirsty. Now your osmolality, this measures the degree of concentration of dilution of the urine. So this is utilized more than osmolarity by providers because they want to determine how many solutes are in the blood and urine. What is the concentration of those solutes? So that's the reason why you may see osmolality listed serum when doctors and nephrologists are good for that. They will write serum osmolality. They want a urine osmolality. So they're going to specify those labs out. The reason is they want to know, okay, how many solutes are in the urine, within the blood and urine for this particular patient. So it gives them an idea of, okay, how is this kidney functioning? If they're overloaded, fluid overloaded, or are they really dehydrated? So that's why they look at the osmolality more so than the osmolarity. So just a little brief note about gerontology. As older adults, there's a lot of considerations. So you always have a lot of risk factors, right? Associated with kidney disease. And advanced age is always the biggest one because a lot of older adults, they have incomplete bladder emptying. They can develop recurrent UTIs. And we see that on a regular basis in the hospital, right? Where older adults come in and they got a recurrent UTI, for whatever organism that may be out there. Men develop benign prostatic hypertrophy, your BPH, disruption of urine flow, leading to frequency or oliguria. Diabetes is another big risk factor, right? Because they develop a neurogenic bladder, or they can develop CKD, chronic kidney disease, right? They can even start with a nephropathy, depending on how severe the diabetes is if they don't maintain control of it. Now, your gout, hyperparathyroidism, your Crohn's disease, and even if you have an ileostomy in place, you're prone to develop kidney stones. So that's another big piece of the pie too. You got to keep an eye on. Hypertension. You have kidney insufficiency. You don't get the blood flow that's needed to the kidney, and you can develop CKD because of it. So instrumentation associated with urinary tract, that's either a cystoscopy was performed or even a catheterization. They can develop incontinence. They can develop UTIs because of it, right? So you definitely got to keep an eye on those. Especially if they're immobile. Immobilization is another big piece. You know, they were in a horrific motor vehicle crash and they're quadriplegic. Well, guess what? They can develop kidney stones if they don't get the correct fluids within their body. Multiple sclerosis is another risk factor because they can develop a neurogenic bladder as well as incontinence. And then OB injuries or tumors. They can develop incontinence, right, over time. And Debbie's nodding her head. I see that. Because especially after having babies, right? So you can have other issues, you know, after delivering babies. Parkinson's disease, incontinence or other complications. Sickle cell disease is another one. Most of your sickle cell patients, they're younger adults, right? They have it at a very young age. And they can develop CKD at a young age. I knew a young lady who was 22 years old. She came in sickle cell crisis when I was working at UCLA, and she developed acute lung injury that they put her on a vent. They didn't think she was going to survive. And they were doing plasmapheresis and all this stuff on her to get her out of crisis. But she had CKD stage 2 or 3, I believe. And by the time she was out, she ended up on renal dialysis because her sickle cell disease crisis was so severe. Yeah, I didn't think she was going to survive, this young girl, but she did. She made it through. And she was placed on the lung transplant list because of it, I believe. I mean, she was really sick. The other 2 items listed here, the spinal cord injury, of course, we know that, you know, they can develop neurogenic bladder incontinence or recurrent UTIs. And spinal cord injuries, depending on what level it is, right? So you got to look at all that. And your systemic lupus erythematosus or your SLE, they can develop nephritis, which I didn't know that. See, you learn something new every day. And chronic kidney disease. So just gives you a little background because especially when you're working in the inpatient side, I mean, it's really important to look at the secondary diagnosis, what these patients have and what they can be affected by when it comes to their kidneys. Now, when we're evaluating the renal function, these are the main tests that we look at, right? The creatinine is one of the biggest things. And this is the result of a breakdown of creatinine. So the amino acid found in the muscles and the brain breaks down within the muscles. So your creatinine breaks down in the muscles, and the amino acid is what is found in the muscles and the brain. Okay. So the kidney filters the creatinine and gets rid of other waste products from the blood and excretes the urine, right? So if there's any dysfunction in the kidneys, that'll increase your serum creatinine level, and then it won't be able to excrete the waste products out of the body. Now, your serum creatinine levels are used to evaluate the efficiency of the renal function. And that's why you're always seeing sometimes with patients with CKD, they want to know, oh, what's the baseline creatinine? Sometimes the docs won't know if they're from out of state. You can't really ask them, right, unless you have a baseline serum creatinine for that CKD stage. So it's really important to look for that documentation. And usually the creatinine is higher in men than women, since it depends on their body size and mass, right? So men are sometimes they're larger than women in body size. When it comes to the other testing, the GFR, the glomerulo, I can't talk today, ladies. Filtration rate, GFR, that's all I'm going to say. This calculates how well the blood is filtered through the kidneys. So, but this calculation is always also based on size, age, sex, and race. So race plays a big role. And your glomerular filtration is a process by which the kidneys filter the blood and removes the excess waste and fluid out of the body. Now, of course, your urinalysis, your UA, it's a visual, chemical, and microscopic tests are done, right? Sometimes, like I said, you may see doctors order the urine osmolality, and that's important because that's a big piece of the pie when it comes to the renal function status. And then, of course, your BUN, your blood urea nitrogen. And this test measures how much urea nitrogen is found in the blood. Okay. So this is a waste product. So we want to get rid of this urea nitrogen because when your liver breaks down, which you're within the liver, and it breaks it down to protein. So the protein is brought back in, right? Reabsorb the amino acids, but urea nitrogen wants to go away. You want it out of your body, right? So it's carried through your blood, filtered out by your kidneys, and then it's removed with the urine. Now, normal range is usually 60 to 20 milligrams per deciliter, okay? But however, I tell everybody, look at what your hospital lab results are, lab ranges are, because everybody has different lab ranges depending on what type of system, what type of testing they do at particular hospitals. Usually this is the normal range that we look at. So let's talk about signs and symptoms associated with poor renal function. Nausea, vomiting, loss of appetite, see that all the time. Fatigue and weakness, sleep problems. They're either urinating more or they're urinating less. They have confusion, decreased mental sharpness. Muscle cramps is another big one. Even fluid retention, swelling of the feet and ankles. Dry, itchy skin. Hypertension, that may be difficult to control. Shortness of breath, if fluid builds up in the lung, right? That's where we're going into our pulmonary edema and our heart failure if they have that particular diagnosis. A chest pain, because they can get fluid built up in the lining of the heart, the pericardium. And then they can even have an irregular heartbeat because of it. Seizures or coma in severe cases, and then of course our electrolyte imbalances, your hyperkalemia, hypernatremia, even your hypochloremia, all right, all of them would be out there. And keep in mind too, sometimes with an irregular heartbeat, if patients have a paroxysmal AFib or a persistent AFib, and they come in with a rapid response, you'll see that more than likely they have some renal issues. And they're always going back to see, okay, what's their history? Do they have CKD? Do they have a nephropathy? You know, or is it something new for them? Okay. So that's something that you can like put together, put the pieces of the puzzle together when you're reviewing that record. So documentation opportunities. What do you think? Of course, it's acuity, severity, and etiology, right? We're always looking for specificity. Acuity, you're acute, chronic, acute on chronic. Severity, is it insufficiency, or is it disease, or is it failure? Etiology, what part of the kidney is involved? Sometimes it may not be the kidney itself, the kidney itself, it could be the adrenal gland that's on top of the kidney, okay? So if the acuity of the renal failure is not documented, it goes to the default code of N19, which is a non-CC and a non-MCC, nor it affects the HCC. So it doesn't, if you get an unspecified kidney code, kidney failure diagnosis, it's not going to affect anything. So you really want to get that acuity captured.
And sometimes the doctors are hesitant. They just put acute renal insufficiency. So that is a good opportunity to find, is it with AKI or is it with CK, chronic renal failure? Because that way, even though they say acute renal insufficiency, at least if they would specify more, like with AKI, then we could capture a CC there. But some doctors are really, what do you call this? conservative about documentation. So I have a nephrologist at Memorial who really is not into everything is renal insufficiency, being cautious about it. But we kept on, kept on asking him or querying him. So, but and that way you're not leading the doctor because he did document acute renal insufficiency. You just want to make sure that is it with acute renal failure or so it wouldn't be a leading question.
Right.
Mhm.
And sometimes it's hard, some of these docs, if they just don't know the patient, like I said, they're traveling, like the contract work I'm currently doing, reviewing records in the state of Florida. Well, guess what? You got a lot of visitors in the state of Florida. They go to a hospital and the hospital says like, well, I'm not really sure what their background is. I don't know what their serum baseline is, creatinine baseline. But they're having problems with acute renal failure. Well, we don't know what's causing it, they never had any history of kidney problems. So, it's really difficult sometimes for some of the doctors to even say, okay, is it really acute renal failure or is it just acute renal insufficiency? Because they don't know their background. They've never had them. They're just passing through, so to speak, heading back north or whatever. So, okay. We're up to chronic kidney disease. Anybody have any questions about any of the anatomy and physiology?
No.
Not yet.
Not yet? Okay.
Not yet.
I said, I think
but
just focusing on the urine formation, because I really think that's part of what we need to look at from a CDI point of view, instead of looking at everything else. I mean, I can go into every little item of function, but it would be so overwhelming. I think that's why I said the urine formation would be a key for us in reviewing the AMP of the kidney, because that way we can understand some of the pathophysiology concepts and why the docs order what they order, especially when it comes to your lab testing. All right. Well, let's start off with chronic kidney disease, CKD. So what is CKD? Well, per definition, it's abnormalities of the kidney structure or function present for greater than 3 months. Remember that. It's got to be greater than 3 months with implications for health. This leads to irreversible kidney function loss. All right. So if a doc does say to you, well, I really don't know what their baseline creatinine is, kidney disease is, because we just diagnosed them with chronic kidney disease. Unknown baseline, they may say. Because why? They have to review lab testing up to 3 months in order to get that CKD stage defined. So when it comes to your diagnostic criteria, and this is trended for a minimum of 3 months, sometimes some of the nephrologists will go 6 months if it's too variable. If it's up and down, it's too labile, and they can't get a good trend, a level off of that serum creatinine. So they're going to look at your decreased GFR if it's less than 60, or they're going to look at your significant albuminuria with excretion rate greater than 30 milligrams in 24 hours. They're also going to look at urine sediment, what's abnormal in the UA, your electrolyte, and other abnormalities associated with renal tubular disorders. Histology abnormalities. Maybe they did a test, a biopsy. What did the path show? Structural abnormalities on imaging. They're going to do a kidney scan, a CT, right? What's going on? What happened? Are they noticing anything? Is there any mass or cysts or stones in there? Do they have a history of a renal transplant? That's another big thing too. You want to keep an eye on that, because sometimes patients, even though they had a history of a renal transplant and they're urinating no problem, they're not on dialysis anymore, they still can have CKD Okay.
I was
So you
just going to ask that.
they still can have CKD stage. As a matter of fact, a nephrologist I worked with at Cedar Sinai, I asked him. I said, "But can't patients still have CKD when after they have a renal transplant, even though they're not on any dialysis any longer?" He goes, "You know what? That's a great question." He goes, "And I need to look into that further." But he did. He got back to us in CDI in the HIM department, and he says, yes, they still can have CKD. So the patient, one of his patients that he saw in the office, he brought us a little case scenario with the patient he saw in the office the day before. And he says, yeah, she still has CKD stage 3A. Even though she's making urine and she's doing okay, she still has CKD. So they're still going to treat her as a patient who has CKD. The renal transplant is working fine. She's making her urine. Renal transplantation is to get off dialysis, whether it's, that's the bottom line. That's why renal transplantation is done. You want to get off dialysis, whether you have peritoneal dialysis or hemo. The goal of renal transplant, get off dialysis. You have a higher quality of life, and you're not stuck being on a machine or doing a 7-hour drain with your peritoneal dialysis. Okay. So you could still have CKD of the kidneys. Now, sometimes it may be difficult for the nephrologist to indicate if the CKD is associated with the kidney transplant or is it from their native kidney. Okay, that's what you got to look for. So if a patient's coming in and maybe they have a rejection going on of the renal transplant, you want to see what else they're writing. So if they rule out that the renal transplant is not being rejected, they may have a CKD associated with that renal transplant. So these are little things that you have to look at in the record because it can be very complicated, when it comes to looking at this. Complications are really difficult, as we all know, from a CDI perspective. And Zenny knows too, from a coding perspective. Because sometimes it's very difficult to say, okay, is it really a complication of the procedure? Or is it a complication associated with something that was done, medical treatment, So it's you got to walk that fine line, because then the docs think, what, you're dinging them, it's a complication. Well, it's a quality ding for them. No, not necessarily. Not, from the coding perspective, but they don't see it in that respect. Okay.
I was thinking more along the lines that there is no rejection. They've had a transplant and they'll just say CKD without a stage.
And
So
they can do that. Right.
Okay.
And that's where your query would come into play for the stage itself. As long as you have a baseline somewhere, or they wrote a CKD stage prior, right?
Okay.
So you can pull that information up from a prior episode, if you're allowed to do that based on your policies, your CDI policies. Some facilities they'll look at and they'll go back on the last admission. The last admission may be a year ago, and it may be documented in there. So just check your policies, in your CDI department, if you are able to go back a year, or is it only 3 months or 6 months? Okay, that's something you got to look at. So just a key note here. If a patient's GFR is greater than 60 and there's no diagnostic criteria to support the CKD diagnosis, as noted above, likely the patient will not be diagnosed with CKD. So you never want to ask for a CKD stage if they don't have the diagnostic criteria listed. If there's nothing in there, you don't want to ask for a CKD stage, even though the doc may be writing it. Instead of asking for a stage, you may want to ask if it's, a rule in, rule out. Is it confirmed or no? It's ruled out. Okay. That's something you want to look at.
And going back to the transplantation, like Anne-Marie said, it's not a cure, but one doctor said they still need to monitor all the labs or for the CKD. So
Right.
The patient may have a renal transplantation, but the CKD can come back. So that's why, as a CDI, we have to look at also the labs, what are the clinical indicators for CKD, so that if we find out that because isn't it renal transplantation is already a CC, right?
Yeah, correct. Yeah.
Okay.
The
So
Z
it's
code,
already a
yeah, it's a
CC.
CC.
But then if, for example, you look at the labs, it looks like the creatinine is getting higher and higher for, let's say, for 3 days or within 5 days, if it's, is it more than five. So we could clarify with the doctor, okay, the patient has renal transplantation, but looks like the CK, I mean the creatinine is getting elevated, like it is consistently getting higher, or the GFR is also getting lower. So you may clarify with the doctor, okay, does the patient has CKD? So that's another way, another opportunity for clarification for the doctor, because
Right.
renal transplantation is not a cure, because the doctor, like I said, the doctor told me that the CKD can still come back, so
Right.
keep an
Right.
eye on it.
Yeah, and nephrologists who are on the case and who know that patient, they're going to write, CKD stage 2 or 3A associated with renal transplantation, because they know that patient from the outpatient side. That's
That's
why I
right.
said it gets a little fuzzy if they're traveling and a patient ends up in the hospital and they had a kidney transplant. Well, they're not sure if there's a rejection or is it a CKD they're developing again, like Christy just mentioned. So that's why you really want to keep an eye on the documentation. And if they're unknown, they have unknown serum creatinine baseline, then I wouldn't send that CKD stage query, because they're going to tell you unable to determine. We don't know, because we don't have all the facts from when they had their renal transplant done.
And CKD alone is not a CC, but it should be failure,
Right.
chronic
Chronic renal
kidney
failure.
failure, yeah, or
Yeah.
chronic renal
Or
failure.
acute.
Yeah. Mhm.
Yeah.
Yeah, so
So
that's
here's
another
our,
opportunity for query, because sometimes the doctor will say CKD. So is it CKD with failure, or it's just CK, chronic kidney disease? So
right. And sometimes they'll say acute on chronic CKD, and acute
mhm.
on chronic
Yeah.
CKD does not match up with acute on chronic renal failure,
Mhm.
because we all
Yeah.
have different codes for those. So that's why it's really important to clarify, is it CKD or is it
But
acute or chronic renal failure?
yeah, but if it's if they put CKD stage 3 and 4, of course that's already a CC.
Or, yeah,
Yeah, 3 and 4. Mm-hmm.
yeah. So, and of course, our breakdown, the G3A and the GFR3B. The reason why they did this, this is from KDIGO guidelines from 2012. CMS wants a measure now because they're looking, remember, they had a core measure, or, the patient safety indicators. They've been looking at end stage renal disease for many years. From a Medicare perspective, for patients who are developing end stage renal disease. And they have a lot of patients who are in end stage renal disease, your Medicare population. Now they decided that, we're going to break down stage 3 to 3A, 3B, because now they're monitoring the stage 3 patients. What they're doing now is they want to see, okay, how fast, they want to trend how fast that patient is at stage 3 or A or B. How fast are they getting to stage 5 or end stage renal disease? So they're looking at it over a period of time, right? So they're running this data. I believe it's going to be for 3 to 5 years, like they did for end stage renal disease patients. So they're going to collect that data, say in another 3 years, because this has been going on for a couple of years now. So now they're going to see, okay, how advanced are they getting, and why are they advancing if they're maintaining the providers are doing what they're supposed to do to maintain best practice and prevent the CKD stage from further decrease of the kidney function, or is the patient being non-compliant with treatment?
I was just going to say patient non-compliant.
Mhm.
That's right. And so that's why it's really important that these doctors do write in their notes that they're being non-compliant with the treatment or their medication regimen. And I say that all the time. And I used to tell the nephrologists all the time, even the hospitalist teams, if they're non-compliant, they're coming back in for a heart failure exacerbation and they're at readmit because they were just here 2 weeks ago for the same thing. You need to be writing this, because this way CMS can review and understand what the trends are. So instead of dinging the providers because they gave them the best practice, right? They went through best practices to treat them, and they're not being compliant with their medication or their treatment regimens. So that's where a lot of education needs to come into play.
Especially with ESRD when they're skipping dialysis and they're ending up in the hospital for dialysis.
Yeah.
Right.
Mhm.
Yeah, that's true. Fluid overload.
Mhm. Even
Or
just one day.
heart failure exacerbation if they have a heart failure diagnosis.
Yeah. And then we have our heart failure readmits because they're not doing what they should be
Yeah.
doing.
There you go. It's a vicious cycle. It really is.
Mhm. It is.
Unfortunately.
Mhm.
Okay. All right. Okay. So additional testing that's done for the CKD, of course, your urine specimen. Usually that's where your 24-hour urine collection is collected for the creatinine clearance. So the docs want to know what is their baseline, what's their creatinine clearance baseline, and that's why a 24-hour urine specimen is collected. And they have to drink a minimum of 8 cups of liquid during the collection day. So they have to drink a lot of water or fluid, whatever. They say liquid, but usually it's water that the docs want. Your GFR, of course, your I can't even say that anymore. Glomerular filtration rate. It's a test used to check how effective the kidneys are working, the flow rate.
Uh-huh.
That's what gives us what the filtration rate is or the flow rate, all right? This is critical to establish a diagnosis of renal disease and management of the CKD condition. Like I said, it may take up to 3 months of testing to substantiate that specific stage. That's why sometimes if they're a new CKD patient, they don't know what their baseline is. They have no idea. They got to do further outpatient follow-ups for a minimum of 3 months of testing in order to figure out what stage they're at. So I would be hesitant to send a query for a CKD stage when they're a new diagnosis. They're going to say unable to determine because they won't know. They got to do further testing. Creatinine clearance is the other one. That's the volume of blood plasma cleared of creatinine per unit time. And this is estimated by using your serum creatinine levels. So the docs will look at the serum creatinine, they'll look at the GFR, but then they'll check a 24-hour creatinine clearance level just to see exactly what it is. I remember collecting those 24-hour urines. It was easy if they had a Foley catheter and boom, put it on ice, and we're all good. Now, if they didn't, it was even harder because sometimes the patients would forget. Oh, I'm sorry, I went to the bathroom. It was like, oops, didn't save it. So now you got to start again. All right. And then serum creatinine levels. Here's the normal ranges for males and females. So on the bottom, I just wrote down just to give you an idea of what abnormalities, the serum creatinine abnormalities may show. So with a creatinine of 2 milligrams per deciliter, it's a 50% reduction in GFR. With a creatinine of 4 milligrams per deciliter, that's a 70 to 85% reduction in GFR. And then your creatinine 8 milligrams per deciliter is a 90 to 95% reduction in GFR. So if they hit a 8 milligram creatinine, they're probably end-stage renal disease and they're on hemodialysis. I've seen 6 and 8. I've seen 10.9 serum creatinine levels in patients, and these were young patients that were on hemodialysis. They were end-stage renal disease. So CKD management, it's called preventative measures. You don't want the CKD to progress, right? So when you're looking at prevention, address risk factors, like we went through with the elderly population, your gerontological population, what impacts the CKD, your cardiovascular health, your BP control, glycemic control, you're diabetic, dyslipidemia, you have high cholesterol, abnormal uric acid levels, you may have gout, acidosis. It could be dietary lifestyle modifications that need to be done. And what's the why? At increased risk to develop AKI or acute kidney injury with above comorbidities. So if you have any of these risk factors, any of these comorbidities, you are at risk to develop CKD, AKI, acute renal failure down the road. So that's why it's really important to keep an eye on that. Now, I did put two tables in here, as you can see, and this tells you the prevalence of CKD complications by the GFR category. This I pulled directly from KDIGO. And the main, as you can see, the main complications, anemia is up there. Hypertension is the highest. Vitamin D deficiency is another high one, as well as acidosis. And then, of course, you have your hypophosphatemia, hypoalbuminemia, and your hyperparathyroidism. So whenever the docs are saying, yeah, and you'll probably see the docs, nephrologists write secondary hyperparathyroidism of renal origin. That's a CC capture. Why? Because that's one of the common complications you will see in patients who have CKD or end-stage renal disease. Now, table 28 I thought was really interesting because of the anemia complication. I think it's important to define what anemia, what thresholds, hemoglobin threshold they use, the providers will use to define anemia. So it has children, non-pregnant females, pregnant females, and men. And it gives you about 15 years of age. And then, of course, your children up to 15 years. I thought that was a nice little cheat sheet to have, because it gives you a little information on what the providers will go by from an outpatient side, but then you can compare it to say, okay, what are they on inpatient? You know, is a non-pregnant female who's 22, what if the hemoglobin isn't 12.0, but it's 9.8? Okay, what's going on with that patient? Why does she have anemia? So I thought that was a nice little cheat sheet to have. Any questions on this?
Oh, just want to add that query opportunity for CKD and hyperparathyroidism, like Anne-Marie said, if it's due to CKD, then it's a CC. So if you see that the doctor documenting hyperparathyroidism at the same time the patient is CKD, you might query, find out, is it secondary to CKD? Then you'll have a CC for that one.
Right. You get that link, especially if the docs don't write the link. Yeah, that's definitely a query opportunity. Thanks, Chrissy. It's really important to have those specified out. And I think it's really important that you know all the complications associated with CKD, because these are the main ones that you would see. And all the patients that we see in the hospital, the older adults, what do they have? High blood pressure, high cholesterol. They maybe have heart disease, right? Or they may have diabetes. You see all those comorbidities with a lot of the older adults today. So that's why you really definitely want to keep an eye on their kidneys to see what's happening. And this is just the cardiorenal syndrome classification. This I pulled out of the National Institute of Health. I thought it was really interesting to see how they listed out your cardiorenal syndrome type 1, 2, 3, 4, and 5. Because you know what? I noticed the nephrologist and even the cardiologist will sometimes write those types in. So it'll give you an idea, the primary event. So what brought them in the door? So if they have CRS type 4, your CKD leading to impairment of cardiac function, increased risk of adverse cardio events. So the primary event was the CKD, but they may have developed coronary heart disease, acute heart failure, or acute coronary syndrome. So I think this was really interesting to see. And they gave you the references, what they used, the rifle criteria, the KDIGO, American Hospital Association, ESC, I don't know, ESC, I'm not sure which company, which organization that is. That could be European. Cardiology group or something, organization, ESC. But I thought it was really interesting to see, okay, they're coming in the door with this. And if you got a cardiology on the case and you got a renal on the case, I said, this is a really good cheat sheet to have too, I think. It gives you just an idea of what they're looking at and how the doctors are treating the diagnoses, when they're coming in the door with something. So, if they come in the door with shortness of breath, it could be anything, right? Depending on what their comorbidities are.
This is good.
Yeah,
Mhm.
I thought that was really, I think that's a really good, helpful little slide to have, little table. I found that really interesting. And I gave you the link on the bottom of the slide. So you should be able to pull it up or copy and paste it into your web browser to pull it all up and look at the article itself. And NIH, sometimes I really find a lot of good stuff in the NIH website as well. Okay, let's talk about coding considerations. So this is directly from CMS.gov website, and it's under ICD-10-CM fiscal year 2024. So this is current year, all right? So your hypertensive chronic kidney disease, you're going to assign codes from category I-12, hypertensive chronic kidney disease, when both hypertension and a condition classifiable to category N19, which is your CKD, are present, okay? CKD should not be coded as hypertensive if the provider indicates the CKD is not related to hypertension. So be aware, sometimes the CKD may be related to something else. 9 times out of 10, it's usually related to hypertension, right? As we all know, that's complication associated with CKD. Now, when it comes to your stages of CKD, ICD-10 classifies CKD based on severity. So this is where all your CKD stages come into play. Coding rules say, yeah, this is how you're going to code, is assigned when the provider has documented that there is an end-stage renal disease. So if both the stage of CKD and end-stage renal disease are documented, you only assign what? Your end-stage renal disease coding. You don't assign a CKD stage because you assign the highest level of severity, and that'll be your N18.6, which is your end-stage renal disease. Now, this is coding rules, guys. So chronic kidney disease and kidney transplant status. Patients who have undergone kidney transplant may still have some form of CKD, like we were discussing earlier, because the kidney transplant may not fully restore kidney function. Based in ICD-10 official coding guidelines reporting page 61 of 120. I should have put that in parentheses, but that's where that came from, that page. Therefore, the presence of CKD alone does not constitute a transplant complication, all right? So you assign the appropriate N19 code for the patient's CKD, as noted on bullet 2, stages of CKD, and then code Z94.0, kidney transplant status. Now your Z codes, I believe all the transplants are still CC captures. So it's always important to make sure you capture those in your coding summary. Now, if a transplant complication such as failure or rejection or other transplant complication is documented, then you're going to go to coding section IC19.G for information on coding complications of a kidney transplant. If the documentation is unclear as to whether the patient has a complication of the transplant or not, you always want to query the provider. It's always important to make sure you clarify that transplant complication for the coders concurrently instead of on the retrospectively on the back end. Now, chronic kidney disease with other conditions, patients with CKD may also suffer from other serious conditions, like what did we discuss? Diabetes, hypertension, even CAD. The sequencing of the CKD code in relation to codes for other comorbidities, contributing conditions, is based on the conventions in the tabular list. So this is where your coders, they're like Zenny, they go to these tabular lists. They have to. That's part of the rules. That's the guidelines. So they're going to let us know from a CDI perspective, hey, we got to change it to this sequencing based on coding guideline. That's fine. That's what we do. Okay.
Thank you, Zinni.
Thank you, Debbie.
Okay. When it comes to CKD versus AKI, CKD cannot be diagnosed on a patient with AKI unless the MD knows the baseline GFR, right? So we've been discussing. It's really important that for patients with unknown baseline GFR, a CKD is unmanageable with IV hydration. It will be difficult for the physician to determine if the patient has CKD or an acute intrarenal pathology. Caution must be taken on querying for CKD or CKD staging, even though the MD has documented CKD as above. Like we said, if you don't have enough of those clinical indicators or the diagnostic criteria, be cautious if you're asking for a CKD stage. If there is an identifiable acute episode, query for the acute diagnosis is more advisable. So, okay, they're saying, oh, they got acute renal insufficiency. It could be acute kidney injury. It could be ATN based on progression, trending the labs. So you always want to make sure you get an acute renal failure or acute kidney injury diagnosis instead of that acute renal insufficiency diagnosis. Make sure you trend your labs though. You don't go by one lab, right? You don't go by one creatinine, one GFR. You got to have several labs in order to trend. And then the impact of documentation. So when it comes to documentation of CKD5 does not equate to ESRD, since not all of your CKD5 patients are on dialysis, right? They may not be. To be able to justify the end-stage renal diagnosis, the patient should be on regular dialysis and not on temporary. So sometimes the patient may come in with CKD5 and they're in fluid overload, so they may have acute renal failure going on top of their CKD5, and they may have to do temporary dialysis, but they're not on it permanent. Unless the doctors say, oh, we got to get a chair, they're going to be on permanent dialysis. That's a different story. Then you can justify that end-stage renal disease diagnosis. CKD 4 and 5 are CCs. Your end stage is an NCC. Of course, your AKI is a CC and your ATN is an MCC. And then your acute on chronic renal insufficiency is not a complication or affects the severity of a diagnosis. That's where your potential opportunity to query for acute renal failure or chronic renal failure is noted. And then, of course, your CKD stages 3, 4, and 5, ESRD, dialysis status, and AKI adds to your HCC risk adjustment. So it's really important, right? Because that's part of your quality initiatives. And the inpatient and the outpatient, because nephrologist gets some extra money from the doctors from the CMS, and the hospital gets extra money from CMS as well. Okay, because it affects both. Your HCCs affect both inpatient and outpatient. That's part of your value-based purchasing program.
I have a question.
Yeah.
Is can the patient with ESRD have AKI? Anybody knows?
Yes, but you have to look at their creatinine and their baseline, because at their end stage they could be a 4, and if they have an acute event, I've had one that went all the way up to 10, but they also had ATN.
Yeah, very good. Yes, yeah. So because there's some confusion, like if the patient has already ESRD, it's end stage already. could it still turn to an acute, kidney failure? So there was like a confusion with the CDI. So we need to clarify it with the nephrologist. And yeah, you're right, Debbie. You have to find out what the creatinine and then you could, the patient can go to AKI even though the
Right.
patient already has ESRD.
Yeah,
Very good.
and the one I had came back down to, I want to say like a 4 or 4.5
Mhm.
after
And that's probably
additional
their baseline.
dialysis and correction.
Yeah, yeah. So that's important. We know the baseline if the patient is
Right.
ESRD because usually their creatinine are very high. But if you know the baseline and it's increasing, so probably the patient is developing AKI, which it's a queer opportunity also. So.
That was a great question. And you know what? I would also say, look at it from one point of view too. Your end-stage renal disease is a chronic condition. So is there anything acute that happened to that patient?
Yeah.
And
yeah.
Debbie, you mentioned it's AKI and the patient went to ATN.
Yeah.
Okay. So your end-stage renal disease, CKD, these are your chronic conditions. All right. They're not acute. So you
And the
definitely want to
patient
keep
was
an
in
eye on the
shock. That's
paperwork,
what
the
they're-
documentation in your labs.
And the patient was in shock. That's what their ATN was from.
Oh yeah, yeah. So
And that'll do it.
Mhm.
Yep. So let's go through AKI. Okay, so causes, pathophysiology, ischemia, hypoxia, and nephrotoxicity. Main feature is a rapid decline in your GFR because of the renal blood flow that's decreased, right? So your three primary etiologies, your pre-renal. We're going to go into this in more in depth too later on. Intrarenal, I'm not going to read all this because we got another particular slide, and post-renal. So your urine studies, urinalysis, you check for hyaline casts, urea level, and your FeNA, your fractional excretion of sodium. You always want to, sometimes they'll order it for AKI, sometimes they don't. Your blood studies, your serum creatinine, consecutive testing, your serum urea again, and your AKI criterion. Now this is courtesy of Pinson and Tang. So do you all have the CDI Pocket Guide or the Unbound book that's online? This is directly from them, so that's why you always want to look at that. Okay. I think it's important. Most of us will go according to increase in creatinine greater than 1 to 5 times baseline known or presumed to have occurred within the prior 7 days. I know we look at that. We usually use that more, I think, from a CDI perspective. Sometimes you may look at the creatinine comparing 2 separate levels, the second one done within 48 hours. I usually look at the 1.5 times baseline because usually we have a baseline going, documented. And then urine volume less than 0.5 milligrams per kilogram per hour for 6 hours. If they're in ICU and they're monitoring their urine, volume, their urine output every hour, you can definitely calculate that based on what the treatment is to kilogram per hours. So that's helpful when they're in ICU. They're really sick. If the etiology of AKI is unknown, a nephrology consult is obtained. Treatment focuses, of course, on the underlying etiology. Did they come in with sepsis? Is it hemorrhage, malignancy, kidney or bladder stones? And of course, what are they going to do? Avoid nephrotoxic agents. You always see that documented by the nephrologist. Even the cardiologist will document that too. Avoid nephrotoxic agents. IV fluid resuscitation. You have your serial chemistry panels. Sometimes they'll do the chemistry panel every 4 to 6 hours, depending on what's going on. If they're really hyponatremic or hypernatremic or hyperkalemic, they're definitely going to monitor that more so than daily. Urinalysis testing too is done. They may do UA testing every 6 hours as well with your chemistry panels. So you just keep an eye on that and look for the trends. Coding considerations for AKI. So when coding the acute kidney injury or acute renal failure diagnosis, Coding instructions also indicate to code the associated underlying etiology. So that's why you really want to know what the etiology is, what's causing that AKI. So when AKI is present on admission and the patient develops ATN, the AKI with the NTN diagnosis is listed as present on admission within the code set, even though the patient didn't have it as soon as they were admitted on hospital day 1. They developed it on hospital 3 or 4. A nephrologist was called in at that time because their serum creatinine kept going up. Their eGFR kept dropping. They don't know what's going on. That's when a nephrologist comes in. No, they have ATN with AKI. Okay. The KDIGO guidelines clearly requires consideration of the previous serum creatinine levels for the current condition in assessing AKI, especially with patients who have a history of CKD. So you always want to look at the KDIGO guidelines too, to see what they're saying. And just FYI, queries using information from prior encounters may be utilized when relevant. That's from the 2022 Actus Ahema Query Practice Brief that was updated this past year, last year. So just keep an eye on that. Because I think it's important that you understand what the KDIGO guidelines are from a CDI perspective, so you can understand the lab testing. You can, try to figure out what the docs are trying to do, how they're going to diagnose that patient. So this is what we were talking about, the 3 types of acute renal failure, your pre-renal, intra-renal, and post-renal. It's really important to recognize the type of renal failure because it'll assist us as the CDS to know what clarification query is needed, as well as the clinical indicators that will justify the clarification. So when it comes to pre-renal, you want to look at the blood flow, right? The blood flow can be affected by the kidneys because of hemorrhage, dehydration, or hypotension resulting in renal hypoperfusion. If persistent hypotension is noted, guess what? They can develop ATN down the road. There is no actual kidney pathology causing the renal failure. Okay, so when it's pre-renal, there's no pathology of the kidney. Pre-renal is usually related to is the most common type of renal failure, and it's usually related to dehydration. That's the main cause of it. And it accounts for 60 to 70% of all inpatient renal failure patients, okay? So IV fluids and treating the underlying etiology will correct the renal failure. So AKI, acute renal failure, you're giving them fluids, likely the cause of the AKI or acute renal failure is your dehydration, okay? That's 60 to 70% of the patients in-house. Now, your post-renal is where there is actual kidney pathology that's caused by an obstruction in order to excrete the waste from the renal calyx to the urethra. Remember that little kidney we had? The renal calyx, that's part of the picture we had. You can go back and look. Causes, usually kidney stones are your big one. Certain cancers though, right? Maybe they have a tumor, they got a mass in the urinary bladder, the colon or cervix even. They could happen on the kidney itself too, right? Blood clots in the urinary tract. Okay, what's causing blood clots to develop? It could be related to a malignancy. Your prostate diseases, your BPH or prostate cancer. They may have a new prostate cancer they just found. A damage to the nerves controlling urine flow and bladder function. And then treatment includes what? Alleviating the obstruction. So that's when your urologists are coming in and doing a cysto or finding out what's going on with that patient. Why are they still having bleeding, blood clots coming out of their bladder? They may have a
kidney stones.
Yeah, kidney stones can cause that too, the hemorrhage, right? So that's why, and kidney stones are very painful. My aunt's had kidney stones. Knock on wood, I don't have any history of that. I drink a lot of water every day. Okay, post-renal obstruction, hydronephrosis. This is a nice little picture to show you, what the normal kidney looks like. If it's a mild hydronephrosis, moderate, and then severe, you have no blood flow whatsoever. And that's the website Christy found it on. And then when it comes to hydro, what is it? It's swelling of the kidney, right? Because there's a buildup of urine, and it's usually due to obstruction of the urine flow. So if left untreated, severe hydronephrosis can lead to permanent kidney damage. So that's really a big piece of the pie. You always want to treat hydro, whether it's mild or mild. You want to make sure you check it and treat it accordingly. Your symptoms, they can have abdominal pain, back and side pains, flank pain, blood and urine, persistent urge to urinate. They could have fever, vomiting, failure to thrive in infants if you do pediatric reviews. Diagnostic tests that are done, of course, ultrasounds, right? Avoiding cystourethrogram. This X-ray imaging just shows a closer look at the bladder to examine how it empties. And this helps to determine if there is urine reflux, which is one of the common causes of hydronephrosis. Think course, a renal scan, they'll do the radioactive material, IV, Gandoleum, something like that, is one of the radioactive meds they give in CTs and renal scans.
Gadolinium. Mhm.
Gandoleum, right? Yeah. And then the doctor looks at it, the kidneys through a special camera. So, of course, urinalysis is done. And then your renal function tests, of course, are done. And treatment, draining excess urine from the kidney, removing blockages. If they drain excess urine, usually a nephrostomy tube is placed. That could be done in interventional radiology. Of course, antibiotics if they have a UTI, and then medications to reduce excess uric acid excretion. Bladder catheter, of course, as well, a Foley catheter. And then your intrarenal, this is where direct damage is on the kidney, and there's a sudden loss of kidney function, and it's usually related to ischemia, infarction, necrosis, or a severely diseased kidney. This is the most complicated kind of renal failure because once you have intrarenal failure, you unfortunately your kidney never recovers from it. Causes could be medication toxicities, that's your infections, leukemia, sarcoidosis, hypertensive kidney disease, your diabetic nephropathy, or dye-induced nephropathy, that's your contrast-induced. Septic shock, of course, and any surgeries. Your types, either acute tubular necrosis, that's what we talk about all the time, our ATN. You may have acute cortical necrosis and medullary necrosis as well, right? Because that's other parts of the kidney. And then your glomerular disease. So when it comes, let's talk about ATN, because that's a big piece of the pie for CDIs, right? So when it comes to your patho testing and treatment, occurs with AKI. You can never have ATN without AKI, right? You always have to have your AKI criteria with your ATN. And this relates to tubular cell injury and dysfunction. So it's an intrarenal etiology, as we know. Your common etiologies that you see, renal hypoperfusion is the biggest one. Administration of nephrotoxic meds, transfusions, severe hypotension, sepsis, septic shock, recent major surgery or rhabdomyolysis. That's really a big one too, your rhabdo. Diagnostic workup must meet AKI criteria, like I mentioned. Receives greater than 3 days of fluid hydration. You may see granular casts or epithelial cells, your muddy casts on urinalysis. In the UA, your urine sodium concentration is greater than 40 milliequivalents per liter, and your FeNA is usually 2% or greater. That's a big piece, your FeNA lab. We received denials for ATN because the FeNA wasn't documented when I worked at Henry Mayo. And then I did some education with our nephrology teams before I left. And they said, you're telling me that they denied the ATN diagnosis because the FeNA wasn't ordered? I said, that's correct. So then they went back and they wrote a letter for us to overturn those denials. One of the docs did for the supervisor.
And we're still not getting FeNAs on any kind of regular basis.
Yeah, it's unfortunate. So anyway, but here's the calculation underneath the FeNA, how the docs figure it out. Treatment and management, of course, treat the underlying etiology, discontinue the nephrotoxications, IV fluid resuscitation, monitoring serum creatinine levels. It's all the same thing that you would do when a patient's diagnosed with AKI, right? Diuretics may be used. That's not part of KDIGO. Nephrologists will try it. They'll do a trial of a Lasix drip or a Bumex drip over 24 to 48 hours to see if that'll improve their kidney function. If it does, they keep it going. If not, they end up starting renal replacement therapy, hemodialysis. And the serum creatinine may normalize within 3 weeks after treatment, or it may take up to 3 months. So that's just gives you an idea of what we look for in the inpatient side, because then the docs will see them on a regular basis, outpatient follow-up. So coding considerations.
Just FYI, if you want to query ATN, well, I use this calculation here just to give the doctor some information on what is the FINA, so at least he could, have additional information to document ATN if he agrees.
Yeah, there you go. Okay, and then our coding consideration for ATN, based upon clinical criteria within the medical record, ATN is always a potential query if a patient was diagnosed with AKI, as this is a more specific diagnosis. But please note, renal function will take more than 72 hours to return to baseline with ATN. May even take days to weeks to return to baseline, depending on the damage of the kidney. Some patients, unfortunately, who do have AKI and develop ATN and end up starting hemodialysis, they may continue temporary hemodialysis on the outpatient side. Not to say that they're going to be strictly on it, but they may have it for several months because the kidney function is coming back a little bit, but they will definitely have some type of CKD because of it. Contrast-induced nephropathy. So CIN is what a lot of the old-time docs will write. Now they're saying that it's contrast-induced AKI. So you really want to take a look at if the docs are writing contrast-induced AKI, you always want to ask for that, because why? It's a CC. Contrast-induced nephropathy, I believe, covers your SOI-ROM. I don't think it triggers a CC capture, though. So this is a syndrome that causes acute renal dysfunction or nephrotoxicity with the administration of contrast agents. Some of these contrast agents, whether they're used for diagnostic and or therapeutic reasons. What I think of all the time when it comes to CIN is your cardiac cath, right? They're always using contrast. They have to in order to see the heart and visualize everything in the heart. Your contrast media considerations may include for diagnosis of CAD, even PAD or PVD, aneurysms, thromboses, malignancy staging, meningitis, pancreatitis. Pathophysiology really is not well defined for this diagnosis. So the etiology that may trigger the contrast-induced AKI may include renal ischemia, there's vasoconstriction, or hypoperfusion. So hypoperfusion is always a big piece of the pie when you're looking at your patients in the inpatient side. So you always want to keep an eye on that. Look for, low blood pressure, persistent hypotension. Is there ischemia going on? Is it renal? Is it kidney ischemia? It could be cardiac ischemia. Your diagnostic measurement that's widely used is your increase in serum creatinine greater than 0.5 milligrams per deciliter, or a 25% increase of serum creatinine from your baseline value at 48 hours after contrast medium administration. So, okay, you got to look at your time frame, okay? When it comes to treatment, there's no specific treatment. Usually they're giving IV fluids, normal fluids, and electrolyte balance. They're just monitoring the electrolyte levels, because they're really not sure of the patho. So it makes it a little difficult for the docs to say, okay, well, we can try it this way. And usually your nephrologist will be called in for this as well. Sometimes the hospitals just aren't sure how to treat it. The cardiologist may be, but maybe they want a second opinion and call the nephrologist in to assist them. So these are just some of the risk factors. I found this on NIH, and contrast media is CM. It's not case management. So just keep an eye on that. But I thought that was really helpful to show, what factors, what are they looking at? And some of these patients who may have these diagnoses may be prone to CIN. Okay. I thought that was really a good little snapshot. Give you an idea, a little cheat sheet, so to speak. And when it comes to coding considerations for CIN, per your Merck manual, contrast nephropathy is acute tubular necrosis caused by an iodinated radiocontrast agent, all of which are nephrotoxic. So since many physicians use the term contrast-induced nephropathy in ATN, it is important to clarify if the contrast-induced nephropathy is AKI and or AKI with ATN based upon the clinical criteria within the record. So it's always important to clarify what it is. And I thought that per Merck manual, they said, no, contrast nephropathy is ATN. So, but take a look at your labs, right? You want to look at your labs. They might not have progressed to ATN, but they may have an AKI going on. All right. Intrarenal, this is your cortical necrosis. This is ischemic necrosis of the renal cortex that leads to a really acute decline in your kidney function with destruction of the renal tissues that filter blood. So causes, for the most part, significantly diminished renal artery perfusion. It could be a vascular spasm, the blood vessel is spasming. It could be a microvascular injury. Maybe they nicked a vessel when they were doing some type of procedure, or there's intravascular coagulation. And that reminds me of maybe they're in DIC. Okay, they're really sick. Diagnostic workup, of course, it's a biopsy that has to confirm this. The docs won't know unless they do a biopsy. And then, of course, our code would be the N17.1, acute kidney failure with acute cortical necrosis. And then your medullary necrosis, there's an acute decline again, of course, of your renal function. And there is, it's within the urine collection that the tubules are destructed. Okay, there's destruction of the tubules. So your causes could be, it could be an analgesic med, your aspirin, Tylenol, or NSAIDs, diabetic nephropathy, kidney infections, of course, or UTI, and your sickle cell anemia. Diagnosis, again, is based on kidney biopsies, so it's really important that you have that information. But also, you can consider your sickle cell diagnosis, your pyelonephritis, and any obstruction present may also help to capture the acute medullary necrosis based on the doctor's documentation and your
Marie,
workup. Yeah.
so if they document it and there was no biopsy, we cannot code that. Because the only way to confirm it is with biopsy.
Well, only way to confirm it, but you can still consider what they're doing. So if they have the other diagnostic workup, your precipitating factors, say they diagnose the patient with pyelonephritis, they diagnose the patient with an obstruction of some sort, or they have sickle cell disease and they're in crisis. So if you have the diagnostic criteria to support that diagnosis, then yeah, I would code it. Zenny,
Okay.
what do you think?
Yeah.
You would code it, right? You would capture it. Because they did document it. You just want to make sure that the clinical criteria is available within the record. So that way you
Okay.
can fight it in case you get a denial down the road, right?
Okay, gotcha.
Yeah.
Thanks.
Yeah,
You're
as long as it's as long as it's documented, I guess you can code it. But if it's not documented, most of the doctors will say, well, we'll have to do a kidney biopsy to make a
Yeah,
definite
like we can't
diagnosis.
query for it without.
Yeah, you can.
a
Yeah, you
biopsy.
can unless,
Right.
yeah, because
Right.
that's
You don't want to
that's the
query for it
answer
if
I
it's
get
not
from them.
documented.
Okay.
Yeah.
But if it's documented, then you can code.
Yeah. Okay. And then your glomerular diseases. So your glomeruli are the tiny network of blood vessels. They're the cleaning units of the kidney, right? So they filter the waste and remove extra fluids from the blood. And then if they are damaged, then guess what? You have a glomerular disease, okay? Many diseases and conditions can damage the glomeruli. So it's really important. There are usually two terms, broad terms, and you'll see this. I know the nephrologists at Henry Mayo and other facilities, they would document glomerulonephritis. That's inflammation or swelling, right? And then glomerulosclerosis, scarring or hardening of the glomeruli. Glomerular disease can damage your kidneys and in some cases lead to kidney failure. So sometimes if you have a young adult and the nephrologist is saying end-stage renal disease, secondary to systemic glomerular sclerosis. They may have an SLE going on, and they have glomerular sclerosis they develop because of that other chronic condition they have. So they're on end-stage renal disease, they're on hemodialysis for life. Okay, so you may see that. Specificity is really, is it acute? Because it's an MCC capture, whether it's glomerulonephritis or just acute nephritis. You got MCC capture. Chronic glomerulonephritis is a CC capture. And that's a slow progression of nephritis. It's not a quick, insidious exacerbation of it. Extent, how is it diffuse or local? Is it greater than 50% of the glomeruli involvement, or is it less than 50%? So it's localized within the kidney itself. And then there's a picture on the right upper corner you can see. All right, documentation challenges. Here's where the kidney transplants, this is where I put it. Overview, kidney transplantation occurs in patients who have end-stage renal dialysis, right? And they're associated with several comorbid conditions, including but not limited to your uncontrolled hypertension, your diabetes, polycystic kidney disease is also, you may see that, and then chronic glomerulonephritis. Kidney transplants are associated with better quality of life and lower risk of death, fewer dietary restrictions too, right? As well as lower treatment costs, right? All insurance companies want to save money, right? So if a patient's on end-stage renal disease and they're young, give them a transplant. Let's drop their costs down. But also, kidney transplant is riskier for patients who are advanced stage, severe heart disease, they're undergoing cancer treatments, they have dementia or poorly controlled mental illness and or significant drug and alcohol abuse. So they wouldn't be a kidney transplant recipient based on that criteria, risk factors. Challenges. Now you have short-term and long-term challenges listed here. I'm not going to read all that. Okay. You can take a look at that. But whenever a patient, do you guys see kidney transplants? Well, Jeannie, you work with mortality cases, right? So you don't do concurrent.
Yeah, I see them. I get to code them sometimes. I don't know. I sometimes get to do concurrent cases.
Okay.
Yeah.
But yeah, well, you want to keep an eye on transplants. I know at Henry Mayo, we don't do them. Transplants. I worked with UCLA, Cedars, and the other hospitals I worked. We did have transplants. We did liver, kidney, lung, heart. They did them all at UCLA. But then
I would say we don't do them at Henry Mayo, but it seems like, I think Zinni can attest to this. It seems like we've had several lately that have had them.
Yes.
That come through the hospital.
They're coming in with problems. Okay. If they're coming in with problems, then you got your challenge, you got your short-term complications and long-term complications, your little cheat sheet you could use if they are having problems with the kidney transplant itself. But just a note, if patients are not on dialysis, ESRD should not be coded. Only code the current CKD stage if applicable. Like we said before, they're not on dialysis, you don't code end-stage renal disease. That's a no-no. And then coding considerations for transplants. This, of course, is from CMS. for fiscal year this year, 2024. Transplant complications other than kidney codes under category T86 and are for use for both complications and rejection of transplanted organs. Now, a transplant complication code is only assigned if the complication affects the function of the transplanted organ, right? You want to make sure that the transplant is affected with the complication. 2 codes are required, the appropriate code from category T86 and a secondary code that identifies the complication. Now, pre-existing conditions or conditions that develop after the transplant are not coded as complications unless they affect the function of the transplanted organs. You got to keep that in the back of your brain. Sometimes it can be very confusing. That's why if they're coming in and they have a kidney transplant, but they're coming in with AKI, now you're thinking, okay, is it affected? Is it the kidney transplant that's causing the AKI? You know, is that the complication of the renal transplantation? Kidney transplant complications. Patients who have undergone kidney transplant may still have some form of CKD, like we were discussing earlier, because the kidney transplant may not fully restore kidney function. So your code T86.1 should be assigned for documenting complications of a kidney transplant, such as your transplant failure or rejection or other transplant complication, like your AKI. Maybe they developed, the kidney transplant developed AKI. Code T86.1 should not be assigned for post-kidney transplant patients who have CKD unless a transplant complication such as failure or rejection is documented. So you always got to go back to your provider documentation, okay? If the documentation is unclear, what are we going to do? We're going to query the provider to clarify, is there a complication associated with that kidney transplant? Case studies. Woohoo! How we doing?
Good. I'm ready for this.
Okay. So am I, because Christy takes over.
Okay. All right. This is a 65-year-old female admitted with fever and leukocytosis. Past medical history significant for chronic renal insufficiency with baseline creatinine of 2.5, hypertension with mixed hyperlipidemia. Workup revealed the following: UA, many bacteria, moderate leukocyte esterase, 0 to 2 hyaline cast, 25 to 50 WBCs, 5 to 10 RBCs, urine cultures more than 100,000 E. coli, and serum creatinine is 2.5 with a GFR of 35. Per H&P, attending provider diagnosed the patient with UTI, renal insufficiency, hypertension, mixed hyperlipidemia. The treatment includes IV ceftriaxone, UA, and urine culture, and avoid nephrotoxic medications. So what is your PDX here?
The UTI.
Mm-hmm.
Yeah, initially the patient has UTI as documented by the attending. So any query opportunities?
We could ask for the stage of CKD.
But we need a couple more days, right? I didn't see
Well,
that.
they said that what the baseline was.
Yeah, the baseline was
Yeah,
2.5.
2.5 and the
Yeah.
2.5.
Mm-hmm. So, yeah, we need to find out because right now the serum creatinine is still 2.5, right? So we need to know whether the doctor can stage this. Anything more?
Not that I see it this. Oh, do we want to know if it's a hypertensive kidney issue? But we need the
There's-
CKD first, right?
The assumed link.
Yes.
Yeah,
Mhm.
that's right.
Yeah,
Causal
yeah.
link,
We need
yep.
to know the CKD, and then and then if it's if it's CKD, then I think it's automatically linked, right?
It is, especially we have the chronic renal insufficiency.
Yeah.
So
Mhm.
yeah,
Yeah.
we
Yeah.
just need the stage. Okay.
Yeah. And the other thing is, just follow up, see what's going on with the patient's vital signs since the patient's UTI. the WBC, and then follow up the labs and see whether the WBC is increasing. I mean, just down the line, is the patient having sepsis? I mean, we don't have enough information here. Just in the back of your mind, see what's going on with the vital signs and the what do you call this? The vital signs and the labs, and of course the patient's symptoms. And I think that's it, right?
And I would, since the culture came back positive with E. coli, I just want to make sure the UTI is associated with the organism. So you capture,
Oh,
that.
yeah.
You know, that's another
Mhm.
potential.
Yeah,
It's
yeah.
simple. Yeah, it's a simple one. You always
Yeah,
want to make
yeah,
sure you're linking the organism with the infectious source.
that's right. It's more specific.
Right.
Okay.
All right. Very good. And then this
Mhm.
is just a sample query.
Oh, yay. Those are always good for me to have.
Mm-hmm. Yep. So you put, the three-legged stool. You have the workup and the treatment and the labs. So it will complete your query, and of course have choices for the doctor, not just just one. So it would be leading. So you just give choices to the doctor, and then the last one is other explanation for clinical findings. So it's like other diagnosis that he think is not part of those other queries.
I was going to say, if we know we have a GFR 35, would we necessarily include CKD 4 and 5?
It's just I mean, for me, I would just include everything.
Okay.
Yeah.
I mean, I know they would. I think there's a HEMA brief regarding query.
Okay.
If it's not, yeah, if
It
it's
has to be
not
clinically
really,
valid. Yes, it has
that's
to be
right.
clinically valid,
Yes.
because if
So
they did accidentally choose that, well, then you would have to send a clinical
that's
validation.
right. Yes.
You wouldn't
Yeah.
want
Yeah.
to put options that
Yeah.
are not
Yeah.
valid.
Mm-hmm. Yeah.
Yeah, that's
Yeah, you're right. You don't want them to, don't give the choice that is not clinically justified.
right.
So if
That's
it's
why
already
that's why I was
35,
asking, because I wouldn't
yeah, yeah,
include
yeah,
4
yeah,
and
yeah,
5
you're right.
personally.
You're right. Yeah. Uh-huh.
Okay.
Mm-hmm.
Yeah, you can
So,
delete some of the CKD stages.
Yeah.
Right.
mm-hmm.
Okay.
Yeah. So
I
you,
just
you just
copy and
take out.
pasted it in there, ladies, so I didn't.
No, I like this. It gives me,
Yeah, yeah,
I'm
yeah,
kind of wordy
yeah.
sometimes with my queries, so I have to be careful.
Mm-hmm. Mm-hmm. Yeah, yeah.
But the
But
other
that's a good.
explanation for clinical findings, that came out of the new practice brief 2022.
Mm-hmm.
So
Mm-hmm.
instead of other, please specify the
Yeah,
diagnosis. That's
yeah.
a good verbiage to use on all your query templates, I believe.
And our,
Should be clinical. There's clinical indicator, like you don't want to ask for chronic respiratory failure if the patient doesn't really have a chronic respiratory failure, right?
right.
So yeah, you're right, Debbie. So okay.
Yep.
All right. And this is just your MSDRG assignments. Once they answer the query for the CKD stage, of course, we pop it in there with the other secondaries or diagnosis code detail on the bottom. And then where would you find it in what MSDRG and then what chapter, MDC?
Okay, number 2, 58-year-old male complaining of urinary retention. In the ED, a CAT scan, anterior, posterior,
Abdomen and
noted.
pelvis.
Abdomen, pelvis, okay. Noted significant hydronephrosis, bilateral kidneys, and a mass on the right renal pelvis, suspicious for malignancy. A Foley catheter was placed in ED with 1,000 liter removed. Serum BUN creatinine noted to be elevated at 34 and 3.6 with no history of kidney disease. Follow-up serial BUN creatinine noted decrease in BUN creatinine of 28 and 3.2, 22, 2.2, and 18, 1.8. Past medical history significant for hypertension, hyperlipidemia, receive IV fluid at a rate of 125 cc per hour. H&P indicated acute renal insufficiency secondary to hydronephrosis and possible kidney tumor. The urology consulted, continue IV fluids and serial chemistry panels. The uroconsult indicated urinary retention likely due to hydronephrosis and suspected bladder tumor. We'll need to biopsy tumor for definite diagnosis. What is your PDX here?
Well, we need the hydronephrosis to me would be the PDX right now because we have acute renal insufficiency and we need to query that.
Okay. So right now we could go to acute renal insufficiency, right? Because that's what the doctor has been documenting. Or it could be the hydronephrosis, right? As a primary diagnosis, because with the HNP indicating acute renal insufficiency secondary to hydronephrosis. So for baseline diagnosis, for now, we could use those. So any query opportunity?
We could ask if the acute renal insufficiency is AKI.
That's right.
Right.
Yes.
Mhm.
Yeah, you could. Yeah. So you could have the more definite diagnosis of AKI. Anything more?
And we want to follow up. Was there a UA result? I'm just thinking if we also end up with a UTI, then you've got pyonephrosis for your PDX maybe, but I don't think, did we say anything about the urinalysis?
No, I don't think
No,
anything
there.
about analysis. So yes, so you just need to follow it up and see, whether it could be, what do you call this? You could clarify that.
Yeah, an
I know we
infection,
have
sure.
AKI because we got down to 1.8 and our initial
Mhm,
increase was
mhm.
greater than the 1.5 and 0.3. Because it
That's
doesn't
right.
say,
Yeah,
and there's no previous kidney disease, so we don't have a baseline.
that's right. Yes. So you could use that the current one, and so querying the AKI.
And chances are our PDX is going to end up being bladder cancer.
Right.
Yeah.
Yeah, most probably. So, is this intrarenal, pre-renal, or post-renal?
Post-renal.
Yeah, post-renal.
Right.
Because there is an
Obstruction.
obstruction,
Yeah.
right? Very good.
Very
Yes.
good.
Mhm. No more query
High five,
opportunities
Jeannie.
right here.
Huh?
Yeah, because hydronephrosis has already been documented, so
Yeah.
that's already a CC.
We've already got
So,
swelling in the kidney and
yeah, and
a
yeah, I
possible
think that's
tumor.
about it.
Yeah. Yeah, that's it. Very good. And here's a sample query.
I love when you put
Yep.
these queries in.
So in this where we did the clinically valid, okay, acute renal failure, choices, acute renal insufficiency without renal failure. They may say maybe the patient doesn't have renal failure. He may
That's right.
still
Yeah,
have acute
yeah.
renal insufficiency.
Yeah.
Right.
So that's
Mhm,
why you want to list both. Okay.
Right.
Yeah.
And it doesn't matter how many choices you give them, right? As long as there's no
They're valid.
specific amount of choices that are allowed based on the AHEMA Actus Practice Brief from 2022.
Mm-hmm.
Okay. But you have your three-legged stool, so you got everything listed out. Okay. And then, of course, our MSDRG is 683 with the CC. What's our CC capture?
What is our CC?
What's our CC, guys?
Hydronephrosis.
Yeah,
Hydronephrosis.
very good.
Yep.
Yeah. And then, of
We
course, all
could end
their
up
other
with 2
secondary.
CCs if we get the bladder tumor confirmed.
Right.
That's
And
right,
then you
yes.
end up with AKI and hydro as 2 CCs, and then you have your bladder cancer as
A
your
primary diagnosis.
Yeah.
very good.
Okay, number 3. It's 89-year-old female admitted with fever, somnolence from a nursing home and was diagnosed with UTI at a nursing home and received oral antibiotics for the past 3 days. However, she became somnolent, not interacting with staff. Vital signs 101.4, 112, respiration 22, and BP is 101 over 49. 911 was called, and paramedics noted to the following vital signs of 101.5, pulse of 116, respiration of 24, pulse ox of 85%, and BP of 92/46. The patient was placed on non-rebreather mask, started IV fluids, en route to the ED. ED provider and attending provider diagnosed patient with sepsis due to UTI with hypoxia. DNR status per nursing home paperwork initiated BiPAP with improvement of oxygenation to 94%. Fluid boluses given ×2 with IV fluid hydration, and patient remained hypotensive. Initiated norepi drip and transferred to ICU. Serum creatinine upon admission through hospital day 5 noted the following: 2.8, 2.2, 1.5, 3.2, and then 3.5. Urine sodium concentration noted to be 40 milliequivalent per liter, and FeNA noted to be 3.5. Nephrology was consulted by attending provider for acute renal failure. Nephrology consult documented prolonged AKI with hypoperfusion as noted with ongoing hypotension. Continue vasopressor per ICU intensivist and wean as tolerated. Initiate IV Lasix 40 milligrams BID. Monitor serum creatinine levels closely. No need for dialysis yet. So what's your PDX here?
Sepsis.
UTI.
Sepsis due to UTI, right?
Yeah.
Okay. So what is your query opportunity?
AKI with ATN due to the hypoperfusion and on vasopressors.
That's right. And what are your clinical indicators for that?
The persistent elevated creatinine.
Yep.
Okay.
And the FeNA.
And the FeNA, yes.
FeNA,
So
yeah.
that would be a good clinical indicators for that query.
I would
And then of
also,
course the treatment.
I would also
Uh-huh.
query for acute respiratory failure.
Yes.
That's
Very
right.
good. Yeah, because the patient was intubated.
No,
Non-rebreather
not
mask.
intubated, but on a non-rebreather. But
Yeah,
And then
non-rebreather
BiPAP.
mask.
Yeah.
And then,
And BiPAP.
and then you
Yeah. And
yeah,
also
and then you
looks like she probably developed sepsis too. I'm sorry, septic shock.
septic shock. Yeah.
Yeah.
What are your clinical indicators here?
The
pressor
altered
support and blood pressures.
and needing
blood pressure.
vasopressors. Mhm. She also
The
has indicators
vasopressor.
for metabolic encephalopathy. She's got it all. She's a
Yeah.
full force.
She's got a lot.
Yeah, because of the somnolence, right? I mean, is the patient having metabolic or septic encephalopathy, right? So you have several query opportunities here: the ATN, and then the respiratory failure, and then the metabolic encephalopathy,
Depending.
and then yeah. And then I would also, since the patient's a nursing home patient, you want to check whether was the patient on a Foley catheter, because the patient has UTI. So is it, a UTI due to Foley catheter? But right here, it doesn't say that the patient had Foley catheter. So you just want to follow up.
Well, and she had a
follow that one.
UTI previously. So the question is, the UTI resolved? And you
I
have
would
to
say
check
they're
that,
probably
yeah.
going to say UTI failed outpatient treatment.
Yeah,
Right.
exactly.
Correct.
Yeah, yeah.
Yeah,
uh-huh.
usually that's what they'll
Yeah.
say.
Yeah.
And of course,
But since
and,
the ER documented sepsis due to UTI, so the patient is still having UTI during this admission. So so just
Right.
follow up if the patient has Foley catheter, so you could link it. And then of course you said the shock, right? So yeah, the patient's very sick.
Yeah. very sick.
Could be
Common
Patient may not
that
make
could be
it.
mortality.
Mortality, that's right. Get that 4 and 4. RSOI.
That's right.
I'm looking
Yeah.
for those Elixhauser and Visiants also.
Oh yeah.
Oh, yeah, that's fun, isn't it?
I've been seeing that in our encoder lately, which I didn't recall from before.
And that's good
What
they're
is
putting it in.
The Elixhauser column.
Okay.
For mortality. Yeah, that's good they add that information for you guys. And this is just a sample.
Mm-hmm. So this is just the sample for the ATN, but like we discussed, there's so many more query opportunities. But if the doctor responded to your query of shock, so it's going to be a septic shock.
Yeah,
Shock, right.
yeah.
Then you'd have an
Mhm.
MCC capture as well.
Mhm.
Sorry about that. Okay.
Mhm.
Our last
So
one.
this is
We're a
case
little
number
over,
4.
so hang in there.
45-year-old admitted with chest pain and diagnosed with STEMI, urgently taken to cath lab for intervention on hospital day number 1, underwent PCI to LAD with 2 drug-eluting stents, past medical history of diabetes type 2 with nephropathy. Hospital day number 3, serum creatinine to 2.4 from baseline of 1.4, then increased to 2.8. Attending provider noted bump in creatinine likely from contrast during cardiac cath procedure. Initiate IV hydration with normal saline at 125 per hour and monitor serum creatinine over the next several days. So what's your PDX?
STEMI.
Demi.
STEMI, yes. Okay. So what are your query opportunities here?
To ask if this is AKI due to contrast-induced nephropathy.
That's right.
Right.
Yes. Yeah. Because you cannot
Yeah, he
assume
didn't
that
say
because
AKI. AKI, he just said
Yeah.
Right, they
they're
gotta link it.
increased.
you're gonna link the AKI, and your clinical indicators are
The
The
creatinine.
elevation of the creatinine.
all right.
They
We know the
initiated
baseline.
the
The
IV
treatment.
fluids and their serial
That's right.
monitoring.
Mhm.
Okay, yeah. So that would be yes. So the main thing here is just linking the contrast-induced nephropathy to AKI. Did the doctor document AKI? No, no.
No.
Okay, so
No.
that's why we need to. Yeah, that's
Bump
right.
in
So we need
creatinine.
to.
Yeah.
Yeah.
And we
Mhm.
already have type 2 diabetes with nephropathy as well.
Nephropathy.
There you
Yeah,
go.
yeah. So
Yeah.
we're good with that one. Very good.
Okay.
Okay.
And that's the sample query.
Excellent. Would we want to, on the third one, the contrast induced ATN, would we want to say AKI with ATN?
Yeah, you can do it that way too.
Okay.
You would
Yeah.
need
Yeah,
another
but
day of labs before you could ask for ATN, though, wouldn't you?
and also we don't have enough information or clinical indicators for ATN. We
Right.
just have the baseline here. We only have the creatinine, although there is what do you call this, the contrast induced
Because it jumped up so much.
nephropathy. So I don't know if it would be enough to ask for ATN,
And right.
but because it's one, I would calculate if there is a FINA. I mean, if there's labs, I
I
would,
was saying
you
maybe the
know,
FINA's
Calculate the
there. We
FINA.
need to look at it.
Then you
and
can
add
add
yeah,
it.
yeah.
more.
Yeah.
So that would,
Or just
that would
delete it
make
from
your,
your
Yeah.
query until you have additional data.
Right.
And it's
Right.
hospital day 3, so you want to look at day 4 data too. So yeah.
Mhm.
yeah, because at least it makes your query stronger, has more meat to it
Yeah.
when you
Right.
have those, especially for ATN. Or you could also look at the urinalysis if there's some muddy, what do you call
Cast.
this, cast. So
Right.
yeah, because with this one, just the IV contrast and the AKI. So
I would be appropriate. Yeah.
yeah.
And delete
So
the ATN.
yeah. So with the number 3, unless you have, like I said,
Yeah,
strong
more
clinical
information.
indicators, I would not
Then
add
pop
that.
it in. Yeah.
Yeah.
If not, take it out.
Yeah. Okay.
Okay. And then this is because of the procedure that was done. So I did add in the principal procedure code with the dilation of the coronary artery, 1 artery with 2 drug-eluting stents, percutaneous approach. And then, of course, it's an MDC 5 under circulatory, and then your DRG would be 247
Mhm.
with your principal and all your secondaries. Okay. Any questions?
Not on that.
No, it's pretty straightforward. Okay, so in summary, we reviewed and applied the pathophysiology, of the kidney through chart reviews, reviewed the CKD stages, the clinical indicators associated with query opportunities, also reviewed our AKI clinical indicators and create a compliant query with specific clinical indicators based upon provider documentation, understand ATN and CIN, and how to create a compliant query with use of specific clinical indicators based upon charting documentation, and went through, reviewed the coding considerations for all of them, and reviewed the DRG assignments. Questions?
I do have one.
Mm-hmm.
Okay. Our case studies were like really kind of straightforward as far as our creatinines. So, and I meant to send this to Anne Marie and I forgot. Patient without a known baseline coming in. I want to say they just had, oh my God, what did they even have? Some respiratory failure. Okay. That was their issue, but they did a routine UA and saw in the creatinine, we don't know the baseline, but the creatinine was 1.1. And then the next day it was 1.2. And the next day it was 1.1. Did have some IV fluids. Doctors documenting AKI. But we don't meet that 1.5 or the 0.3.
Mm-hmm.
I had a patient like this, and then the patient was discharged. I didn't code the AKI because to me it didn't meet
Mm-hmm.
by the time of discharge. We didn't know the baseline. And I'd gone back to look, and it was the first time the patient ever been here, so I didn't have back information to go through. But on a chart review, it was said that I should have coded the AKI.
I think it should
Yeah, I
have
would
had
have
a
sent,
clinical validation query.
that's right. Clinical validation query should have
And
been
you
sent
can't
on
just
that.
not code it. So you either have to capture it or you have to send the query.
Mm-hmm.
Right.
Okay.
Isn't it there was I don't know if it's changed that if the doctor documents it, the coder should code it.
Yeah.
I
Right.
mean,
Well, that's always been for
correct.
coding, and
always been like that, right? But then if it doesn't meet the criteria, I mean, I don't know with Henry Mayo, but at Kaiser, the coders will query the doctor first and see is the patient really have AKI before coding it. So
the thing is, when we
yeah.
do clinical validations, they tend to again say it because unfortunately they consider it when we send a validation, which something we're trying to work on, that we're questioning their judgment versus asking them to
Mhm.
take a second look. So they tend to just say it because they think you're questioning them.
You're
I know.
And
challenging
it
the
Yeah.
ends up being a
diagnosis.
denial.
Yeah.
We're actually getting denials now on AKI.
That's right. So yeah, because yeah, that's always a problem with validation because the doctor thinks you're questioning them.
Mm-hmm.
But in this facility, previous facility I work, our PA would present it to the doctor and say, okay, this was denied. They send you a query. Something just doctor to doctor really is
Peer
the
to
most
peer.
yeah, peer-to-peer is most effective, but I don't know how some other processes in some facilities, but I think just do the validation. They say yes or no. I mean, at least you did your part, and then if it gets denied, you cannot be blamed because you did your parts.
Right.
Right.
When we
True.
do clinical validation, we provide them with, we have a lot of institution specific diagnosis that, been agreed upon. And of course, in this situation, you could use the KDIGO criteria that here's the KDIGO criteria. This is what the patient had. Please clarify if the patient had AKI, if it was ruled out, or yes, they have it, and please provide additional clinical indicators to
Those
support this
indicators.
diagnosis.
Right.
Okay.
Mhm.
Yeah,
Those
that's
are
a
the
good way of
choices we
raising
give
it.
too. Yeah.
Or you could say with based the Codigo, is the AKI ruled in still or ruled out? But
Yeah.
on those lines, so at least you're still saying it's ruled in. I mean, you're not saying that he's wrong, but because
Right.
you gave the choice of AKI.
Yeah.
But I think again, is it ruled out because of that?
The KDIGO
What do you call this?
criteria, or do you
Indicators.
think it's
Yeah.
still
Uh-huh.
ruled
Yeah.
in?
Yeah. Yeah.
Yeah, a couple of the
So,
doctors I've talked to, when I say, they said, well, when I've tried to express to them that the validation is just for like a second look and
yeah.
to re-verify just a second look at it, it calmed down like immediately.
Yeah.
So really
Yeah, I
been
know.
trying to use that language with them.
I think
Mhm,
maybe the
mhm.
query template needs to be revised a little bit to what Jeannie was mentioning and what, I agreed with her because there are a couple clinical validations that are very straightforward. It's like, here's your criteria, here's what's in the medical record, and then your choices include, is the AKI ruled in? Please
Give additional.
specify additional clinical
Uh-huh,
indicators associated with
Yeah,
this
yeah.
diagnosis, and then
Okay.
you give them lines, and then no, AKI has been ruled out, or then, or whatever. But I think it's
Okay.
important that they need to specify what's the additional clinical
Yeah.
evidence, clinical indicators to
Mhm.
support the AKI diagnosis.
Yeah,
Yeah,
'cause we're
yeah.
getting crazy denials on that stuff now.
Yeah, yeah, yeah. And
Denials on
that
everything.
should be presented to them that the AKI is being denied, how many
Right.
percentage being denied, so they would understand, the
Yeah.
impact. Because AKI is also HCC, right?
Yeah.
So it also
Right.
impacts their money. If it's denied, it's taken out of their diagnosis, so it impacts their
That's
money.
right.
So,
Okay.
Yep.
We're keeping the money.
It's all
Okay.
about the money.
Thank you for viewing RN Link webinar. To obtain 2 CEUs, accepted by BRN, Actis and AHIMA, please copy and paste the link below. Don't forget to subscribe, share and click the notification buttons.